Hello everyone. Today we're going to be going over neurological disorders and the therapeutic management for those neurological disorders. I'd like to start off and talk about coma. So awareness is the combination of cognition, so that's mental and intellectual, and mood, and that can be construed based on the patient's interactions with the environment. Alterations of consciousness may be the result of deficits in awareness, arousal, or even both. The four discrete disorders of consciousness are coma, vegetative state, minimally conscious state, and then locked-in syndrome. So those are the four discrete disorders of consciousness. Coma is characterized by the absence of wakefulness and awareness, whereas a vegetative state is characterized by the presence of wakefulness with the absence of awareness. In the minimally conscious patient, wakefulness is present and awareness is severely diminished, but not absent. Locked-in syndrome is characterized by the presence of wakefulness and awareness, but with quadriplegia and the inability to communicate verbally. So, the patient appears to be unconscious. Coma is the deepest state of unconsciousness. Arousal and awareness are lacking. The patient cannot be aroused and does not demonstrate any purposeful response to the surrounding environment. So, coma is a symptom rather than a disease, and it occurs as a result of some underlying processes. The incidence of coma is difficult to ascertain because a wide variety of conditions can induce coma. This state of consciousness is unfortunately very common in the critical care area, so you can be sure to see this whenever you start practicing. So the causes of coma can be divided into two general categories: structural or surgical. Structural or surgical, and then metabolic or medical. Structural causes of coma include things like ischemic stroke, intracerebral hemorrhage, trauma, and brain tumors. Metabolic causes of coma include drug overdose, infectious diseases, endocrine disorders, and poisonings. There is a review box. It's 24-2 in your books, so you probably want to take a look at that to look at some of the causes of coma. So wakefulness and awareness are absent in the presence of coma. Ascending fibers of the RAS, or the reticular activating system, maintain arousal as an autonomic function. So remember, we talked about the autonomic nervous system in one of the first lectures, and so the autonomic nervous system controls the reticular activating system. Excuse me. Neurons in the cerebral cortex are responsible for awareness, and then diffuse dysfunction of both the cerebral hemispheres and dysfunction of the autonomic nervous system in the reticular activating system can produce coma. Now, structural causes usually produce compression or dysfunction in the reticular activating system, and most medical causes lead to dysfunction of both cerebral hemispheres. The clinical diagnosis of the comatose state is readily established by assessment of the level of consciousness. However, determining the full nature and cause of coma requires a thorough history and physical exam. Assessment of pupillary size in reaction to light, extraocular eye movements, and then motor response to pain, breathing pattern yields important clues for determining whether the cause of coma is structural or metabolic. So all of those assessment findings are important in the neuro patient. Laboratory studies and diagnostic procedures are also done. Structural causes of coma are usually apparent with MRI or CT scans And then laboratory studies identify metabolic or endocrine abnormalities. Evoked potentials are useful in facilitating a differential diagnosis between the disorders of consciousness and in evaluating a patient's prognosis. So now a little bit about medical management and nursing management. The goal of medical management is to identify and treat the underlying cause of coma. Now, initial management includes emergency measures to support vital functions and prevent further neurological deterioration. Administration of thiamine, glucose, and opioid antagonists is suggested when the cause of coma is not immediately known. Thiamine is administered before glucose because the coma produced by thiamine deficiency or Wernicke encephalopathy can be precipitated by a glucose load. The patient who remains in coma after emergent treatment requires supportive measures to maintain physiologic functions and prevent complications. So we're talking about intubation and then, turning the patient, the standard types of nursing care that you would provide for patients who were comatose. The healthcare team and the patient's family usually are the ones that make decisions, and it's done in a joint collaborative effort regarding the level of management to be provided. Family members require information on the probable cause of coma and prognosis of recovery, so that's one of the primary things that the nurse can help with facilitating. Now, prognosis depends on the cause of coma and the length of time unconsciousness persists. The outcome for an individual cannot be predicted with 100% accuracy. So the use of hypothermia has been shown to improve neurological outcomes and survival rates in patients with coma where it was from cardiac arrest. Primarily it's cardiac arrest, and then also head trauma. Sometimes hypothermia may be indicated in neurological trauma patients. Nursing management of coma patients incorporates a variety of nursing diagnosis, and it's directed by the coma's cause. Nursing interventions focus on monitoring for changes in neurological status and clues to the origin of the coma. Also, it includes supporting body functions, watching for complications, providing for comfort and emotional support, and initiating rehabilitation measures. Measures to support body functions typically include things like pulmonary hygiene, skin integrity, range of motion exercises, managing bowel and bladder function, and ensuring adequate nutritional support. Loss of protective mechanisms, such as the blink reflex, which is also called the corneal reflex, or the ability to keep eyes closed, result in drying and ulceration of the cornea, which can lead to permanent scarring and blindness. So it's important to use some kind of a lubricant and place it in the eyes, and sometimes even taping the eyelids shut. Alternatively, saline drops is used pretty frequently, and as well as taping, using something to tape the eyes down, tape the eyes closed. Okay, the film, you should take a look at box 24, TAC 3, further to review the nursing diagnosis in coma, and then also box 24-4, which is collaborative management of coma patients. Okay, now let's talk a little bit about stroke. So, stroke is a descriptive term for the sudden onset of acute neurological deficit persisting for more than 24 hours and caused by the interruption of blood flow to the brain. Stroke is the fourth leading cause of death in the United States, and strokes are classified as either ischemic or hemorrhagic. Hemorrhagic strokes can be further categorized as subarachnoid hemorrhage and intracerebral hemorrhage. Although less common, hemorrhagic strokes have a higher mortality rate compared to ischemic strokes. And there's a concept map on figure 20, it's figure 24.1, that will be helpful for you to look at. So let's now move to ischemic stroke. So ischemic stroke results from an interruption of blood flow to the brain and accounts for 80 to 85% of all strokes. The interruption can be the result of thrombotic or embolic events. Strokes are preventable. Most thrombotic strokes are the result of an accumulation of atherosclerotic plaque in the vessel lumen. The greatest risk factor for ischemic stroke is hypertension. Other risk factors are dyslipidemia, diabetes, smoking, and carotid atherosclerotic disease. Common atherosclerotic plaques, the sites are at the bifurcation of the common carotid, the origins of the middle and anterior cerebral arteries, and the origins of the vertebral arteries. An embolic stroke occurs when an embolus from the heart or lower circulation travels distally and lodges in a small vessel, obstructing the blood supply. At least 20% of ischemic strokes are attributed to a cardioembolic event. The most common cause of cardioembolic event is atrial fibrillation, and ischemic stroke is the definition of ischemic stroke is a cerebral I said that incorrectly. So ischemic stroke is a cerebral hemodynamic insult. When cerebral blood flow is reduced to a level that is insufficient to maintain neural viability, and ischemic injury occurs. In focal stroke, an area of hypoperfused tissue, so that area is hypoperfused, and we call this the ischemic penumbra. And this is surrounded by a core of ischemic cells, ischemic cells. And the ischemic penumbra can be salvaged with return of blood flow. However, sustained anoxic insult initiates a chain reaction of biological events that leads to apoptosis and then cell death. TIAs, or transient ischemic attacks, are brief episodes of neurological symptoms that indicate stroke is likely to occur, and sudden onset indicates embolism. Stroke size depends on the vessel that is occluded and the availability of collateral blood flow. Global ischemic results when severe hypotension or cardiopulmonary arrest provokes a transient drop in blood flow to all areas of the brain. And complications include cerebral edema and secondary hemorrhage at the site of stroke. So, let's talk about the first question. Which of these is the greatest risk factor for ischemic stroke? I'll give you a second to take a look there. So, the answer is C, and the greatest risk factor for ischemic stroke is hypertension. Other risk factors are dyslipidemia, diabetes, smoking, carotid atherosclerotic disease, and atrial fibrillation. But the most important one, the one that contributes most to the risk, is hypertension. A little bit about assessment and diagnosis now. So the characteristic sign of an ischemic stroke is the sudden onset of a focal neurological deficit or sign that persists more than 24 hours. These signs usually occur in combination, and changes in the level of consciousness are usually usually occur only with brainstem or cerebellar involvement, seizure, hypoxia, hemorrhage, or increased intracranial pressure. The NIH, or the National Institutes of Health, has a stroke scale that is often used for focused examination. And you all actually learned this stroke scale early in the semester when you completed the online course. The score ranges from 0 to 42 points, and the higher the score, the more neurologically impaired the patient is. Confirmation of the diagnosis of ischemic stroke is the first step in emergent evaluation. Differentiation from intracranial hemorrhage is absolutely important, and non-contrast CT scanning is the method of choice for this purpose. MRI can demonstrate infarction of cerebral tissue earlier than can the CT, but it's less useful in the emergency differential diagnosis. Other tests that should be acquired include the 12-lead EKG, a chest radiograph, continuous cardiac monitoring, echocardiography can also be valuable in identifying a cardioembolic phenomenon that's associated with stroke. Laboratory evaluation of hematologic function, electrolyte and glucose levels, and then kidney and liver function is also recommended. Arterial blood gas analysis will be performed if hypoxia is suspected, and an EEG is performed if seizures are suspected. An LP, or lumbar puncture, is performed only if subarachnoid hemorrhage is suspected and the CT scan is normal. So there is a box on box 24-5 that goes over the neurological abnormalities in acute ischemic strokes. So the medical management of ischemic stroke includes a few different measures. So to start off, let's talk about fibrinolytic therapy. So fibrinolytic therapy with intravenous recombinant tissue plasminogen activator is recommended within 4.5 or 4.5 hours of the onset of stroke. And that's an important number to remember, because if you work in a stroke center, this is the target that if someone arrives in the ER, this is the time frame in which they should be treated with fibrinolytics, and that's 4.5 hours from the onset of the ischemic stroke. CT confirmation of diagnosis must be accomplished before TPA is administered. This is to ensure that you don't have a patient who has a hemorrhagic stroke, but rather an ischemic stroke from an embolic event. And the way that you're going to be differentiating that on the CT scan is, so on a CT scan, blood, if there's blood present in the cranial vault, it will appear white, rather than if it's a embolic stroke, there will be no real profound changes besides maybe some intracranial shifting from cerebral edema, but there won't be any white appearing areas of blood. So the desired result of fibrinolytic therapy is to dissolve the clot and reperfuse the ischemic brain. The goal is to reverse or minimize the effects of stroke. And the major risks, obviously, are bleeding, especially intracranial hemorrhage. And the major barriers to effective application of fibrinolytic agents for ischemic stroke are pre-hospital and in-hospital delays. And that's why it's so important to ensure that everybody's on the same wavelength to that 4.5 hour mark. Okay. So other emergent care of the patient with ischemic stroke must include airway protection and ventilatory assistance to maintain adequate tissue oxygenation. Hypertension is often present in the early period as a compensatory response, and in most cases, blood pressure must not be lowered. For the patient who has not received fibrinolytic therapy, antihypertensive therapy is considered only if the diastolic blood pressure is greater than 120 or the systolic blood pressure is greater than 220. The criteria are different for patients who have received TPA. Their blood pressure is kept below 180 over 105, and this is done with medications to prevent, and ultimately what this is going to do is going to prevent hemorrhage. So the key here is if they have not received TPA, then their blood pressure, there's a higher threshold at which the blood pressure will be maintained. And then once they receive TPA, that's when we want to institute blood pressure control. So in the targets, again, just to repeat those, if the blood pressure, initially, if they have not received TPA, the diastolic blood pressure should be no greater than 120, and the systolic should not be greater than 220. And then once they have received TPA, their blood pressure is kept between 180 over 105. All right. And there is a table, it's table 24-1, that goes over the blood pressure management for stroke according to the American Stroke Association guidelines. So medical management also includes the identification and treatment of acute complications such as cerebral edema or seizure activity. Prophylaxis for these complications is not recommended. Now, deep vein thrombosis prophylaxis, however, should be initiated to decrease the risk of pulmonary embolism. Surgical decompression is recommended if a large cerebellar infarction compresses the brainstem. Okay, so now we're going to talk about subarachnoid hemorrhage. And subarachnoid hemorrhage is basically bleeding into the subarachnoid space, which usually is caused by rupture of a cerebral aneurysm or an AVM, which is an atriovenous malformation. Known risk factors for subarachnoid hemorrhage include hypertension, smoking, and alcohol or stimulant use. Cerebral aneurysm rupture accounts for roughly 85% of all cases of subarachnoid hemorrhage. An aneurysm is an outpouching of the wall of a blood vessel that results from weakening of the vessel wall. Now, 90% of aneurysms are congenital. The rest may be caused by traumatic injury or infectious materials, or the cause may actually be unknown. Multiple bilateral aneurysms do occur in approximately 30% of cases. So we have to ask ourselves, what does it mean that the aneurysms may be bilateral? And what this means is that they are occurring on the same location on both sides. And this really has to do with the blood flow and turbulence and resistance that is met, and it sometimes happens bilaterally. So an AVM rupture is responsible for roughly 6% of all subarachnoid hemorrhages. AVMs may be small focal lesions or large diffuse lesions that occur almost an entire hemisphere, that occupy an entire hemisphere. And there's a table 24-2 goes over aneurysm classification and according to what type and location and common characteristics. Okay, so now let's take this picture here. Just kind of shows some of the common areas where aneurysms can form. And as the individual with a congenital cerebral aneurysm gets older, blood pressure rises, and more stress is placed on the poorly developed and thin vessel walls. And once ballooning of the vessel occurs, this gives the aneurysm a berry-like appearance. Aneurysms are usually small, 2 to 7 millimeters in diameter, and often at the base of the brain, on the circle of Willis. The aneurysm becomes clinically significant when the vessel wall becomes so thin that it ruptures, sending arterial blood at a very high pressure into the subarachnoid space. In other situations, the unruptured aneurysm expands and places pressure on the surrounding structures. A similar picture can be found in Figure 24, Tac 2. The pathophysiologic features of an AVM are related to the size and location of the malformation. One or more cerebral arteries, also known as feeders, can supply blood to the AVM. These feeder arteries tend to enlarge over time and increase the volume of blood that is shunted through the malformation, and it increases the overall mass effect. Large, dilated, tortuous, draining veins develop as a result of increasing arterial blood flow being delivered at a higher than normal pressure. And unlike arteries, veins have no muscular layer and become extremely engorged and rupture easily. Some patients with AVMs also have cerebral atrophy. It is the result of chronic ischemia because of the shunting blood through the AVM and away from normal cerebral circulation. The patient with a subarachnoid hemorrhage characteristically has an abrupt onset of pain, described as the worst headache of their life, and a brief loss of consciousness may be present, along with nausea, vomiting, focal neurological deficits, and a stiff neck may accompany the headache. That stiff neck and headache and all these signs and symptoms are signs of meningeal irritation. Excuse me. The subarachnoid hemorrhage may result in coma or death. The patient's history may reveal an incidence of sudden onset of headache with vomiting in the weeks preceding a major subarachnoid hemorrhage. These are small warning leaks of an aneurysm in which small amounts of blood ooze from the aneurysm into the subarachnoid space, causing a headache, a stiff neck, and photophobia. And this is all signs of meningitis. Symptoms of unruptured AVM include headaches with dizziness or syncope or fleeting neurological deficits. And then also, the diagnosis of subarachnoid hemorrhage is based on clinical presentation, CT findings, and lumbar puncture results. So, a non-contrast CT scan is the cornerstone of diagnosis, and remember that's the blood is going to show up as white where the bleeding has occurred. In 90% of cases, CT demonstrates blood in the subarachnoid space if performed within the first 48 hours of the hemorrhage, so it's a very sensitive test. If the initial CT finding is negative, an LP or lumbar puncture is performed to obtain a cerebral spinal fluid sample. If CSF after subarachnoid hemorrhage appears bloody, CSF does appear bloody after a subarachnoid hemorrhage. Therefore, when they do the LP, there will be a high red blood cell count, greater than 1,000 cells per millimeter cubed. If the lumbar puncture is performed more than 5 days after the subarachnoid hemorrhage, The CSF fluid is dark amber, and the technical word for that is xanthochromic. The blood becomes darker because the blood products have broken down. After the subarachnoid hemorrhage has been documented, a cerebral angiogram is necessary to identify the exact cause of hemorrhage. If a cerebral aneurysm rupture is the cause, angiography is essential for identifying the exact location so that surgery can be performed. After the aneurysm has been located, it is graded using the Hunt and Hess classification scale. If an AVM rupture is the cause, angiography is necessary to identify the feeding arteries and draining veins of the malformation. In your books, box 24/7 goes over the Hunt and Hess classification of subarachnoid hemorrhage. So subarachnoid hemorrhage is a medical emergency, and preservation of neurological function is the goal, and early diagnosis is crucial. Initial treatment must support vital functions. A ventriculostomy is performed to control ICP, or intracranial. A ventriculostomy is performed to control intracranial pressure if the patient's level of consciousness is depressed. Evidence suggests that only 19% of deaths attributable to aneurysmal subarachnoid hemorrhage are related to the direct effects of the initial hemorrhage. Rebleeding accounts for 22% of deaths, cerebral vasospasm for 23% of deaths, and then neurological medical complications for 23% of death. The principal non-neurologic causes of death are SIRS, or systemic inflammatory response, and then secondary organ dysfunction. Rebleeding is the occurrence of a second subarachnoid hemorrhage in an unsecured aneurysm. And finally, less commonly, an AV malformation. Evidence suggests that rebleeding has more to do with variations in blood pressure than it does with the absolute values that blood pressure control does not lower the incidence of rebleeding. Definitive treatment for the prevention of rebleeding is surgical clipping or endovascular coiling with obliteration of the aneurysm. The timing of the operation is key to the medical management issue. Patients commonly are taken to the operating room within the first 48 hours of rupture. This early surgical intervention to secure the aneurysm eliminates the risk of rebleeding and allows more aggressive therapy to be used in the postoperative period for the treatment of vasospasm. The surgical procedure involves a craniotomy to expose and isolate the area of aneurysm. A clip is placed over the neck of the aneurysm to eliminate the area of weakness. It's not uncommon, particularly in early surgery, for the clot to break away from the aneurysm as it is surgically exposed, resulting in extensive hemorrhage. So figure 24-4 shows a clipping of a posterior communicating artery aneurysm. The solid curved line shows the typical skin incision, and the dashed lines show the craniotomy location and the application of the aneurysm clip. Management of AVM has traditionally involved surgical excision or conservative management of such symptoms as seizures and headache. The decision for surgical incision depends on the location and the size of the AVM. Some malformations are located so deep in the cerebral structures that attempts to remove the AVM would cause severe neurological deficits. Surgical incision of large AVMs includes the risk of reperfusion bleeding. Evidence of reperfusion bleeding in the operating room is an indication that no more arterial blood can be diverted from the AVM without the risk of serious ICH, or intracranial hemorrhage. In the postoperative phase, a low blood pressure is maintained to prevent further reperfusion bleeding. So these patients need very good blood pressure control. For large AVMs, 2 to 4 stages of surgery may be required over 6 to 12 months. Embolization is used to secure a cerebral aneurysm or an AVM that is surgically inaccessible because of the size, location, or medical instability of the patient. Embolization involves several new interventional neuroradiology techniques. All of the techniques use a percutaneous transfemoral approach in a manner similar to an angiography, and it's done under fluoroscopy. The catheter is threaded up to the internal carotid artery. Specially developed microcatheters are then manipulated into the area of the vascular anomaly, and embolic materials are placed endovascularly. And this basically embolizes the area. 2 embolization techniques are used depending on the underlying pathologic derangement. The first type of embolization is used to embolize the AVM. Small polymeric silicone beads, or glue, is slowly introduced into the vessels feeding the AVM. Blood flow carries the material to the site, and embolization is achieved. The second type of embolization involves placement of 1 or more detachable coils into the aneurysm to produce an endovascular thrombosis. So the figure in 24 TAC 5 shows endovascular occlusion of a posterior communicating artery aneurysm. And A shows an insertion of a microcatheter into the aneurysm through the right femoral artery, the aorta, and then into the left carotid artery. And then B demonstrates occlusion of the aneurysm with coils. The presence of the presence or absence of cerebral vasospasm significantly affects the outcome of aneurysmal subarachnoid hemorrhage. Cerebral vasospasm is a narrowing of the lumen of the cerebral arteries, possibly in response to the subarachnoid blood clots that coat the outer surface of the blood vessels. Because the aneurysms usually occur at the circle of Willis, the major vessels responsible for feeding the cerebral circulation are affected by the vasospasm. Depending on the arterial vessels involved in the vasospasm reaction, decreased arterial flow occurs in large areas of the cerebral hemispheres. It is estimated that 70% of all subarachnoid hemorrhage patients develop vasospasm. So this is a complication that we really need to keep our eyes open for when we're caring for these patients. The onset of vasospasm is usually 3 to 12 days after the initial hemorrhage. 3 treatments are commonly used, and these treatments I want you to key into, and you'll hear them referred to pretty much in every lecture you'll ever hear, and that is induced hypertensive, hypervolemic, hemodilutional therapy, or what we call triple H therapy. And then that's number 1. And number 2 is oral nimodipine. And number 3 is transluminal cerebral angioplasty. So medical management is the Triple H therapy and nimodipine, and then the surgical management is a surgical procedure is a transluminal cerebral angioplasty. Triple H therapy involves increasing the patient's blood pressure and cardiac output with vasoactive medications and diluting the patient's blood with fluid and volume expanders. Hemodilution facilitates flow by reducing the blood viscosity. There is a risk of rebleeding in an unsecured aneurysm with Triple H therapy. Surgical clipping of the aneurysm before Triple H therapy is preferred. And that kind of makes sense, right? Because if you have not clipped the subarachnoid hemorrhage, if you haven't clipped the aneurysm, and then you induce hypertension, then you're going to increase the likelihood of a aneurysmal rupture. So, nimodipine is strongly recommended to reduce the poor outcomes associated with vasospasm. A dose of 60 milligrams of nimodipine is given orally every 4 hours for 21 days. Nimodipine may produce hypotension, especially when administered concurrently with other antihypertensive agents. Cerebral angioplasty is used when pharmacologic management has failed. It is performed only when CT or MRI provides evidence that infarction has not occurred. An interventional neuroradiologist performs the procedure. The technique is very similar to that used in the coronary vasculature. Risk factors include intimal perforation or rupture, cerebral artery thrombosis or embolism, recurrence of stenosis, and severe diffuse vasospasm unresponsive to therapy. Hyponatremia develops in 10 to 43% of patients with subarachnoid hemorrhage as a result of salt wasting syndrome. It usually occurs several days after the initial hemorrhage. The use of fluid restriction to treat hyponatremia in subarachnoid hemorrhage patients is associated with poor outcome. So for you, if you're working in the ICU or on a floor where you're caring for these patients, you're going to be monitoring the chemistry panel, and the sodium level is highly important to key into. Hydrocephalus is a late complication that can occur from subarachnoid hemorrhage, and it occurs in roughly 25% of patients. Basically, blood that has circulated in the subarachnoid space and has been absorbed by the arachnoid villi may get obstructed, and it may obstruct the villi and reduce the rate of CSF absorption. Over time, the increasing volume of the CSF in the intracranial space produces a communicating hydrocephalus. So this basically will lead to an increase in CSF in the subarachnoid space. Treatment consists of placing a drain and removing the CSF, either with a ventriculostomy, which is a temporary measure, and then a permanent measure would be the ventriculoperitoneal shunt. So, intracranial hemorrhage is bleeding directly into the cerebral tissue. Intracranial hemorrhage destroys cerebral tissue and causes cerebral edema and increases the intracranial pressure. So remember from previous lectures that the intracranial pressure normally should be less than 10 millimeters of mercury. The source of intracerebral bleeding is usually a small artery, but it can result from rupture of an AVM or an aneurysm. Spontaneous intracranial hemorrhage accounts for at least 10% of all stroke admissions. The mortality is unfortunately pretty high. 50% of patients will die within the first month, and then only 20% of patients will return to normal function after 6 months. The key risk factors is age-associated cerebral amyloid angiopathy and then hypertension. Intracerebral hemorrhage is most often caused by hypertensive rupture of a cerebral vessel and resulting from a long-standing history of hypertension. Other possible causes of spontaneous intracranial hemorrhage are anticoagulation or fibrinolytic therapy, coagulation disorders, drug abuse, and hemorrhage into a cerebral infarct or brain tumors. Often the patient admits to having discontinued antihypertensive medications roughly 2 to 3 weeks before the hemorrhage. The pathophysiology of intracranial hemorrhage is caused by continued elevated blood pressure that exerts force against small arterial vessels that have become damaged from atherosclerotic changes. Eventually, these arteries break and blood bursts from the vessels into the surrounding cerebral tissue, creating a hematoma. Intracranial pressure rises precipitously in response to the increase in the overall intracranial volume, and then initial assessment usually reveals a very critically ill patient who often is unconscious and requires ventilatory support. History from a relative or significant other describes a sudden onset of focal deficit, often accompanied by severe headache, nausea, vomiting, and rapid neurological deterioration. Approximately 50% of patients sustain early loss of consciousness. More than 1/2 of the patients with intracranial hemorrhage present with a smooth progression of neurological symptoms, an uncommon finding in cases of ischemic stroke or subarachnoid hemorrhage. 1/3 of patients have maximal symptoms at onset, and then assessment of vital signs usually reveals a severely elevated blood pressure. Signs of increased intracranial pressure are often present by the time the patient arrives in the emergency department. Diagnosis is established with CT scan, and as we discussed before, angiography is recommended only in patients considered surgical candidates and if clear cause of hemorrhage is not evident. And the key here on the CT scan, that blood is going to show up as a large white area or small white area, and it's going to be in the parenchyma or in the tissues of the brain. Intracerebral hemorrhage is a medical emergency, and the initial management requires attention to the airway, breathing, and circulation. National guidelines recommend the mean arterial blood pressure be kept below 130 in patients with a history of hypertension. By moderate blood pressure reduction to maintain a mean arterial pressure below 110. Vasopressor therapy after fluid replenishment is recommended if systolic blood pressure falls below 90. Increased intracranial pressure is common within intracerebral hemorrhage and is a major contributor to mortality. So it's very important to make sure that we're monitoring intracranial pressure closely. Recommended management of intracranial hypertension or elevated intracranial pressure includes mannitol when indicated. Hyperventilation should be limited, but sometimes is used when an acute immediate neurological deficit is noted. Neuromuscular blockade with sedation may also be indicated. The cerebral's perfusion pressure should be kept higher than 70 millimeters of mercury, and this is to maintain cerebral perfusion. The goal of fluid management is euvolemia, with a recommended pulmonary artery occlusion pressure of 10 to 14. So this is just within the normal range. We know that the normal pulmonary artery wedge pressure is 12, and 10 to 14 is the normal range. Body temperature should be maintained to less than 38.5 degrees Celsius. And then euglycemia is maintained with insulin therapy. Use of short-acting benzodiazepines or propofol is recommended to treat agitation and hyperactivity. We are now moving away from benzodiazepines, so typically nowadays we're going to be either using propofol or dexmedetomidine is another medication that we can use. Pneumatic compression devices also are going to be used to decrease the risk of pulmonary embolism from DVT. Prophylactic anticonvulsant therapy is sometimes used. The benefit of surgical treatment for spontaneous intracranial hemorrhage is unclear. Recommendations for surgical removal of the clot depend on the size and the location of the hematoma. The patient's intracranial pressure also is one of the factors that will help us determine if they should get surgery, and then also their neurological symptoms. Medical treatment is recommended if the hemorrhage is small or neurological deficit is minimal. Surgical evacuation of a clot is recommended for patients with cerebellar hemorrhage greater than 3 centimeters, as seen on the CT scan, with neurological deterioration or hydrocephalus with brainstem compression, as well as young patients with moderate or large lobar hemorrhage with clinical deterioration. And there's some evidence-based guidelines for practice in the patient with spontaneous intracerebral hemorrhage. It's in box 24.8 in this chapter. The nursing management of the patient with stroke incorporates a variety of nursing diagnoses. The nursing interventions focus on monitoring for changes in neurological and hemodynamic status, maintaining surveillance for complications, providing comfort and emotional support, and educating the patient and family. The goal of frequent assessment is early recognition of neurological or hemodynamic deterioration. Close monitoring of the patient's neurological signs and vital signs are essential and requires almost continuous observation. It is essential that all personnel working with the patient be aware of the desired hemodynamic and neurologic parameters set by the physician, and the physician be notified at the first signs of any changes. The patient with stroke should be monitored closely for signs and symptoms of bleeding, vasospasm, increased intracranial pressure, and other complications. Additional complications that may be seen in the patient with stroke are related to the area of the brain that has been damaged. In the patient with a cerebral aneurysm, sudden onset of an increase in headache and nausea and vomiting, increased blood pressure, and changes in the respirations herald the onset of rebleeding. And so this particular slide right here is very important to remember and to key in on, because rebleeding is one of the major things that we're looking for as nurses at the bedside. The first indication of vasospasm is usually the appearance of a new focal or global neurological deficit. And then subarachnoid hemorrhage precautions must be implemented to prevent any stress or straining that could potentially precipitate rebleeding. Many signs and symptoms of increased intracranial pressure can be observed, and a few of them include a change in the level of consciousness, and it is the most sensitive indicator, a change in the LOC. Other changes include unequal pupils, decreased pupillary light response, headache, projectile vomiting, altered breathing patterns, Cushing triad, diminished brainstem reflexes, papilledema, and abnormal extension or flexion posturing. Patients with non-dominant hemispheric pathologic conditions may exhibit emotional liability with periods of euphoria, impulsiveness, and inattention. These patients also may suffer from agnosia, visual field deficits, and apraxia. Agnosia is a disturbance in the perception of familiar sensory information, such as verbal, tactile, and visual. Unilateral neglect is a form of agnosia, characterized by an unawareness or denial of the affected half of the body. Some patients are unable to recognize objects visually. This is called visual object agnosia, whereas others cannot recognize faces, and this is called prosopagnosia. Tactile agnosia is a perceptual disorder in which a patient is unable to recognize an object that has been placed in his or her hand by touching alone. Spatial orientation is affected, resulting in interference with the patient's ability to judge position. Also, distance, movement, form, and the relationship of his or her body and body parts to the surrounding objects. Stroke patients may also experience reading and writing problems related to the visual perception and visual spatial deficits. Visual field deficits may accompany agnosia, although they do not cause it. A hemispheric lesion can interrupt the visual pathways, with the resulting visual defect dependent on the location of the extent of the lesion and the extent of the lesion. Visual defects restricted to a single field, right or left, are called homonymous hemianopsia. Lesions in the parietal lobe and in other cortical structures can result in apraxia, an inability to perform a learned movement voluntarily. Even though the patient may understand the task to be performed and may have intact motor ability, he or she cannot perform the task and often fumbles and makes mistakes. The patient suffering from dressing apraxia, for example, may not be able to orient clothing in space, becoming tangled in his or her clothes when attempting to dress. Damage to the dominant hemisphere produces problems with speech and language. Impaired communication is a condition that results from a patient's difficulty in expressing and exchanging thoughts, ideas, or desires. Aphasia is a loss of language abilities caused by brain injury, usually to the dominant hemisphere. It affects what the individual is attempting to interpret or convey through listening, speaking, reading, writing, and gesturing. Most causes of aphasia are partial. Receptive aphasia, also referred to as sensory, Wernicke, or fluent aphasia, occurs when the connection between the primary auditory cortex in the temporal lobe and the angular gyrus in the parietal lobe is destroyed. The patient's comprehension of speech is impaired, but he or she can still talk if the motor area of speech or the Broca area is intact. Patients with receptive aphasia also cannot read words, although they can see them. Expressive aphasia, also known as motor Broca or non-fluent aphasia, is primarily a deficit in language output or speech production. Expressive aphasia can range from a mild dysarthria, where you have imperfect articulation as a result of weakness or lack of coordination of speech, to incorrect intonation and phrasing, and in most severe form, to complete loss of ability to communicate through verbal and written means. Global aphasia results when a massive lesion affects the motor and sensory speech areas. The patient cannot transform words and cannot comprehend spoken words. All language modalities are affected, and impairment may be so severe that the patient may be unable to communicate on any level. Normal swallowing occurs in 4 phases that are controlled by cranial nerves. Damage to the brainstem, or cranial nerves may result in a variety of swallowing deficits that can place the patient at risk for aspiration. The stroke patient is observed for signs of dysphagia. A speech therapy consult is initiated if dysphagia signs are present, and the patient must not be orally fed. In the absence of these warning signs, the patient may be fed, as ordered by the physician, although he or she must be continually monitored for signs of aspiration. Rehabilitation starts in the critical care area, with the multidisciplinary team designing and implementing an individualized plan of maximizing the patient's potential for neurological rehabilitation. Early in the patient's hospital stay, the patient and family must be taught about stroke, its causes, and its treatment. As the patient moves toward discharge, teaching focuses on the interventions necessary for preventing the recurrence of the event and on maximizing the patient's rehabilitation potential. The patient's family must be encouraged to participate in the patient's care. They must also learn how to feed, dress, and bathe the patient, and learn some basic rehabilitation techniques. The importance of participating in a neurological rehabilitation program or support group, or both, must be stressed. Okay, this concludes the lecture for this hour, and I'm going to start up the next lecture discussing Guillain-Barré syndrome and some other neurological disorders.